Hello. I want to spend the next few minutes talking about a pretty thorny issue in medical education in the United States, and that is pass rates on board exams for both DO physicians and MD physicians. So let's just jump in here. There are two pathways to becoming a physician in the United States. The MD pathway is the more traditional one, but the DO pathway is equally valid. Both DOs and MDs can be pediatricians and surgeons and anesthesiologists, all the various specialties. I specifically work in the DO pathway, so I'll be talking a bit about that. To become a DO or osteopathic physician, one must take certain licensing exams at a certain point during your medical education. And these are called the COMLEX USA licensing exams. The first one is taken after your second year. The second one is taken after typically your third year, and the third one is taken during residency. What's alarming here and what the problem is that over the last few years, we have seen a decline in pass rates for DOs or DO students when they attempt these licensing exams. You can see here in this simple little graphic just a few data points showing that the pass rates for both ICOM graduates and also the national pass rates have been declining. With the class of 2026, which is the most recent group to take their level 1 licensing exams at an all-time low. Similar trends are seen for MD graduates as well. So the question we have here before us is, what is causing this decline in pass rates and how might we actually try to fix it? Now, it might be tempting at this point to say, well, 90% pass rate, that's perfectly fine. But with somewhere around 30,000 students attempting level 1 or step 1 licensing exams every single year, we're talking about 3,000 potential failures. This is a massive number, especially once these students have put in so much effort to get to this point. So I'd like to first talk about this problem on this Cynefin matrix that is shown here, and make it clear that the rates at which students are passing or failing these exams is incredibly complex. And that's because there are so many factors that control, affect, or influence what these pass rates might be. So there are some constraints, but they're loosely coupled. It's not a really simple cause and effect. So what we see here, that some of the actual factors that probably influence pass rates are, well, what are the pre-matriculation student characteristics? What are the students like before they enter medical school? How smart are they? In other words, what's their academic horsepower? Additionally, we live in a post-COVID world. I'll talk a bit more about that in just a moment. But COVID has had a significant impact on our student population. Our students' needs have changed. They're demanding more mental time off so they can recharge their batteries, and that appears to be having an influence. We know that medical information is doubling. In fact, current estimates show that the amount of information out there, the amount of medical information is doubling every few months. This is just due to the massive amounts of publications of medical information. There have been changes in these licensing exams, and in fact, they have been made more difficult. And then finally, we have AI. We're not sure how AI might be influencing this, but it probably is as well. All of these put together make it so that if you change any one of these or study any one of these points, it's likely to affect the others. And so we have a truly wicked problem here. So let's talk a bit more about the borders or kind of the edges of this problem. For example, how has COVID-19 caused lasting impacts? We know that during COVID-19, over and over again, we were told that we needed to take care of ourselves, that we needed to watch our emotional, mental, and behavioral health. And that's indeed true. And current medical students were undergraduates just 4 or 5 years ago when COVID was happening. And they heard this message over and over again. So they're now in medical school and they're remembering that. And so when they're being asked to study huge amounts, when they're being asked to put in hour after hour after hour of grinding study to pass these exams, more and more of them are saying, well, hold on, I need to take care of myself. So it seems to be causing some of them to let off the accelerator and not work as hard. Why was the exam made harder? We believe that is mostly because there was evidence that students were coming out into residency and they were not completely prepared. We know that the mental health of college and medical students is at an all-time low, and that's across the world really and across all disciplines. The reasons for this are complex, but when students have decreased mental health, they are unlikely to be successful on these very rigorous, very difficult exams. And then what about AI? There is now increased evidence that the use of AI might be short-circuiting the clinical acquisition of skills that med students need in order to become competent physicians. So if they've been relying on AI, they likely do not have the same problem-solving skills that their predecessors may. So how can we actually study this problem? The first one would be, of course, using this idea of expansive learning. Here's a definition of expansive learning that I wrote earlier today. Expansive learning is an educational theory where humans work together in collaborative and transformative ways to understand complex phenomena, and then use that understanding to solve problems and advance new knowledge. So in my mind, and this is quite simple, expansive learning involves two really important parts: people working in groups and using novel ways to solve problems. This little pyramid graphic is a representative image of how this actual expansive learning works. I don't have the time to go into that, but I want you to think for a moment of how truly complex it is to understand the modern medical student. We have groups that could work on this problem or think about it that are in admissions, that are looking at the curriculum. We would need mental health professionals to study our students and see why they might be having struggles, which of course contribute to perhaps their inability to pass these exams. We have residency program directors. These are the physicians that are capturing our students once they graduate, and they know about their competence or their lack thereof. And then of course, eventually we would want to look at health outcomes from the actual patients that our students are actually treating. Are our students competent enough, and have these declines in passing rates caused a change in their ability to actually deliver competent health care? Now, another way we could tackle this, and indeed we would need to, is by looking at the massive amounts of data that are flowing out of medical education in the United States. Just as an example, there are approximately 50,000 applicants to medical school every year in the United States. Around 30,000 will graduate each year, and around 100,000 licensing exams will be attempted each year. All of these data are flowing to colleges through various groups and are being collected. In fact, two of the main places where these data are being collected, and as a dean I have access to a fair amount of this data, is through the AAMC, which is the American Association of Medical Colleges, and AACOM, which is the American Association of Colleges of Osteopathic Medicine. They're tracking a lot of this data and have actually started to put together perhaps what's contributing to some of these issues. Of course, another place, and there are many other places in which we're collecting data, is looking at exit and climate surveys of our students. So I want to hear in just a minute, because I don't have much time, to give you the beginnings of a model for how I would study and look at this at the Idaho College of Osteopathic Medicine. First, in terms of looking at this from an expansive learning point of view, we need expert teams that are able to focus in on their area of expertise. So for example, look at this graphic that I've made. We'd have an admissions team that's looking at the pre-matriculation metrics of our students. We have a curriculum team that's looking at the curriculum of the medical school. Is it sufficient? Is it actually training the students to pass these exams? We have competency testing, meaning once the curriculum has been delivered, are they actually being assessed in their knowledge in a reasonable way? And does that testing represent the kind of testing when they'll take their actual licensing exams? What about their behavioral health? At ICOM, we have a behavioral health team that meets with students when they're having struggles. Now, a lot of what goes on there is private, but we can have access to some of that data in terms of how many of our students are using behavioral health support. And then eventually we have graduate student outcomes. In my model, each one of these teams, which already exist at ICOM, would feed data. Of course, that data would be appropriate and it would be cleaned of identifying information whenever necessary. That would flow back into a data flow and assessment, either team or dashboard, where that data could be collected. Some of it would be summarized and analyzed there, but eventually it would be passed on to a final group, which is the Student Success Working Group panel, of which I actually am the chair because this group actually already exists. Now, currently, the Student Success Working Group doesn't look primarily at this board exam issue. It's looking at other issues as well. But this is something that needs to rise, higher and higher on the radar of this group. I think the only way you're going to tackle this are these expert groups. There's going to have to be the collection of a lot of data, and that data is going to have to be analyzed by those expert groups because they're the only ones that truly understand it, and then it flows back eventually through dashboards, both software systems, all the way to the Student Success Working Group, which then can look at the data and then make recommendations. You'll notice in this little graphic here, all of these lines are double-headed arrows because clearly based upon what the Student Success Working Group determines, they would need to then feed information back to admissions or back to our curriculum and say, look, based upon what we found, if we tweak our admission standards in this way, we might be able to get a different type of student which has a higher chance of success on these actual competency exams. Or in the same case with curriculum, based upon what the working group determines, they might be able to feed information back to the curriculum team and say, we need to tweak our curriculum in these 6 areas because we've noticed our students are weak in these areas and our curriculum appears to be weak in these areas as well. There's no way for the actual Student Success Working Group to control all of these areas, but they can feed information to the various expert groups. That is my very quick overview of the model of how I would tackle this problem, and it indeed does involve the various theories that I presented. Here are my references, and I appreciate your time. Thank you.